All right, everybody, welcome back to Discussions with Dr. G. I'm Dr. G, resident Gen X nurse, lover of cats, caffeine, and seeing my students finally get the difference between left-sided and right-sided heart failure on the exam. Today, I'm tackling one of those topics that most nursing students fake confidence their way through, heart failure and the wild adventure of its meds. So let's start with the literal heart of the matter. What the heck is heart failure anyway? It's not just your heart giving up. Although sometimes it kind of feels like it, especially when you've been teaching 3 days in a row. But medically, we're talking about the heart being unable to pump or fill effectively. Cardiac output drops, fluid builds up, your body's major organs get the short end of the oxygen stick, and everything just sort of slows down. Think lungs filling with fluid, kidneys getting cranky, and the rest of your organs plotting their revenge. Now, I always tell my students, heart failure is less about drama and more about decades of bad decisions. Hypertension, coronary artery disease, cardiomyopathy, toss in a little MI for flavor, maybe even some valvular disease, or COPD if your patient's feeling spicy. And don't forget obesity and dysrhythmias. Those are lovely additions. Your basic recipe for heart trouble. And let's not forget the body's so-called helpful responses. Your SNS and RAS kick in. All, let me help you out, heart. But plot twist, what starts as adaptation soon turns to sabotage. More fluid, higher afterload, and that classic cardiac remodeling that just ruins everyone's day. Now, when it comes to symptoms, we're basically splitting between left and right-sided failure. Left-sided, think lungs, dyspnea, orthopnea, all the weird ways that people stack up their pillows at night to breathe easier, pulmonary edema, and those lovely crackles that make auscultation totally worth it. Right-sided, think whole body, JVD, ascites, peripheral edema, hepatomegaly, everything swollen except what the patient thinks is swollen. I kid you not, I once had a patient who was absolutely convinced her left foot was right-sided swelling, and vice versa. Turned the whole assessment into a vaudeville routine. I cannot make this up. Just a reminder that your assessment skills and a sense of humor will go a long way. So, overall impact, we're talking activity intolerance, fatigue that's practically Olympic level, fluid retention, and everyone's perennial favorite, frequent hospitalizations. Heart failure is basically the unwanted gift that keeps on giving. But hang on, because up next, I'm spelling out how all these meds work their magic, or sometimes mischief. So let's crack open that medicine cabinet, shall we? The big hitters in heart failure start with RAS inhibitors. So ACE inhibitors like lisinopril, ARBs like valsartan, those ARNIs everyone keeps mispronouncing, and spironolactone, the potassium-sparing darling. These guys chill out your RAS, so there's less vasoconstriction, less fluid hanging around to cause trouble, and they can even stop your heart from rearranging furniture. That's maladaptive remodeling if you want to be nerdy. Just, watch out for hypotension, hyperkalemia, renal issues, and if you're using ACEs, a cough that refuses to quit, or angioedema, which is always a party killer. Nurses, keep an eye on that blood pressure, the potassium, creatinine, and whatever you do, do not throw in a potassium supplement unless you want to see fireworks. Next, my personal favorite for keeping people calm, beta blockers. Carvedilol, metoprolol, bisoprolol. They slow down that frantic SNS, lower the heart rate, help with remodeling too, but start low and go slow. Like your grandma crossing an icy driveway. And please, watch asthma and COPD patients. Otherwise, you're going to get bradycardic and wheezing, a combo no one wants. Cue the diuretics, because who doesn't love watching a patient lose 5 pounds of water in a single shift? Loops like furosemide, thiazides, and again, spironolactone. Out with the sodium and water, hopefully out with all that congestion, but just when you think you're winning, bam, hypokalemia, That's with loops and thiazides. Or hyperkalemia if you're liberal with the spironolactone. Then there's dehydration, hypotension. You get the idea. Track those labs, daily weights, and find a way to explain potassium balance that doesn't make your patient's eyes glaze over. Don't sleep on the new kids. SGLT2 inhibitors, empagliflozin and dapagliflozin. A little diuresis, some cardiorenal protection, but keep your radar up for UTIs, genital infections, DKA, diabetic ketoacidosis can sneak up on you, even if the patient is not diabetic. Weird, right? Okay, deep cut here. HCN blockers, like ivabradine. These are handy if beta blockers aren't tolerated. They drop the heart rate without tanking contractility. But here come the warnings. No AFib. Watch the drug-to-drug interactions like a hawk, and please, for the love of the kidneys, no grapefruit juice. Why? Because one day you'll forget and the NCLEX will haunt you with it forever. Also, visual changes, luminous phenomena. Yeah, patients really do notice it. No, it's not a superpower. Vasodilators come next. Hydralazine, nitrates, even nitroprusside if you're in the ICU. Arterial, venous, or both, all trying to take the pressure off the heart. Just keep in mind, hypotension, headaches, syncope, and renal impairment are all on the menu. Precautions for orthostatic hypotension, and remember the sodium teaching. Nobody listens, but you still gotta say it. Let's get a little bit more intense. Inotropes and vasopressors. Digoxin is the old classic. It squeezes a bit harder, helps in certain rhythm issues, but the window between helpful and toxic is tiny. You want to be the nurse who catches the early vision changes or GI symptoms before it all goes south. Trust me. If your patient's seeing yellow, suddenly doesn't have an appetite, those are red flags. Dobutamine and milrinone for your sickest patients, usually in the ICU only. And vasopressors, epinephrine, norepinephrine, dopamine, vasopressin, these are the big guns for shock, serious decompensation. Administer carefully. Monitor like a hawk. And honestly, patients and families need a lot of education and reassurance here, because nothing about vasopressors says routine care. ICU settings for these only. I know this is a ton to keep straight, so think in terms of chronic versus acute. Most folks at home or on the floor get RAS inhibitors, beta blockers, diuretics, maybe even an SGLT2 inhibitor. Those other categories, vasopressors, inotropes, high-dose vasodilators, those are your ICU full monitor patients. And always double check your labs, your vitals, and maybe your life choices before you sign off on a new order. Just saying. So this is where you're really going to shine. A little something I call the nursing gut plus clinical judgment magic mix, or CJMM. Copyright pending. Start by recognizing cues. Bradycardia, dyspnea, the patient who's suddenly stacking 3 pillows again, rapid weight gain, edema creeping up, JVD making another comeback. Maybe they're hypotensive or have weird arrhythmias, or the electrolyte labs looking like a slot machine payout. Analyze what's up. Is it fluid status getting out of hand? Are those meds actually working or just irritating the kidneys? Sometimes you gotta hold a med if the patient's vitals are off. Don't be afraid to page the provider. Prioritize oxygenation, fluid balance, and hemodynamics. If it's never a bad idea to question a new prescription if the potassium or creatinine is trending the wrong way. Action time. Give meds safely. Keep checking labs. Potassium plus magnesium, creatinine, digoxin level. Teach your patients. I always beat the check your weight daily drum. Seriously, a few pounds can mean the difference between staying home or heading back to the hospital. They need to know the drill. Low sodium diets, fluid restriction if prescribed, which, side note, does not mean swimming. True story, I had a patient once who thought fluid restriction was about avoiding the pool, not the water in their cup. Medication purpose, self-monitoring, pulse and blood pressure, when to panic and call for help. These are critical. And tell them to avoid NSAIDs whenever possible. Trust me, ibuprofen ruins hearts faster than the country breakup song. Self-care matters too. No smoking, go easy on the booze, stay active as tolerated. So here's your summary shot. Ivabradine slows the heart, keeps folk out of the hospital a bit longer. Vasodilators lighten the heart's workload, but can zap blood pressure and kidneys. Inotropes are potent, but risky. Vasopressors are ICU only, life-saving, but not for daily use. The cornerstone meds are still RAS inhibitors, beta blockers, diuretics, SGLT2 inhibitors. Everyone else chimes in for special situations. Nurses, yes, you are pivotal. Safe med administration, vigilant monitoring, proactive teaching, and using that clinical judgment magic every step of the way. That's what changes outcomes for heart failure patients. And this stuff is tough, but it's manageable, especially if you intervene early and teach like a pro. All right, that's enough heart failure fun for today. You know the drill. Take care of yourselves and your patients. Keep learning, and I'll see you next time. Signing off.